The broadcast is now starting. All attendees are in listen-only mode.
Good evening, Leon van Rensburg, RSSA Congress Director. Welcome again to another in our series. It's actually the 9th out of 10 lectures on this mini course on head and neck radiology presented by Professor Richard Wiggins, Director of Head and Neck Imaging, Department of Radiology and Imaging Sciences, Otolaryngology, Head and Neck Surgery, and Biomedical Informatics at the University of Utah Health Sciences Center, Salt Lake City. At the onset, I again want to thank Richard for his commitment to do this course and series of webinars over the course of this year, and especially allowing us to record these lectures for future reference. And it is an absolute commitment to international training and education in head and neck radiology. Tonight, Dr. Wiggins will talk on lower cranial nerves. At the end of the lecture, there will be opportunity for you to post questions, compliments in the inbox by email, and we'll take that from there. Thank you very much. Over to you, Rick.
Okay, thank you, sir. Hello, everyone. Today we're going to talk about the lower cranial nerves. And I have nothing significant to disclose. So we're going to talk about the how we image these, and for each of these cranial nerves, we'll look at their anatomy and talk about their anatomy on graphics and look at their anatomy on imaging, and then look at pathology that happens to that anatomy and look at the important anatomy around these areas. So for all of the cranial nerves, anytime we have an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. So if we're in the pons, we think about the middle cranial nerves 5 through 8 having their major part of their nuclei there, 1 through 4 being above in the mesencephalon, and 9 through 12 being below, and the medulla going down towards the cord. So we're going to talk today about the lower cranial nerves down lower. But again, anytime we have an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. So usually that's starting behind the pontomedullary junction and going out through the face. And we remember that each of these cranial nerves has their own important foramen around the skull base. So we talked about cranial nerve 5 before, and we talked about 7 and 8 going through the internal auditory canal. Today we're going to talk about the lower cranial nerves, 9, 10, and 11, and 12, and focusing on the important anatomy around the jugular foramen. So we think about these holes in the posterior skull base, and also all these cranial nerves that we think about going through that anatomy. So here in this coronal view, where we think about where the pons and the medulla are, we see the 6th nerve coming out here at the pontomedullary junction. 7 and 8 usually actually come out the bottom of the pons, but we think about them going over to the IC. Here we see 9, 10, and 11 all going over the head of the buzzard, kind of in the sagittal view, and this coronal plane through the occipital condyle. And then we have 12 coming out below it. So this is some important anatomy right here centered around the jugular foramen when we think about the lower cranial nerves. So we'll look in some detail about this imaging on graphics, and then we'll look at it on imaging, and then we'll look at pathology that happens around this area. So we're going to start off talking about the anatomy of these important cranial nerves. And we know that below the skull base, where these nerves all come out, we think about where the carotid and the jug are if we're looking at the bottom of the skull base here, and we think about where 9, 10, 11, and 12 are all coming out around that area, and how all of those nerves that extend down in the superhyoid neck, and what we often talk about is the carotid sheath or carotid space, or the poststyloid peripharyngeal space, if you prefer that nomenclature. So we have the carotid, the jug, and we have parts of cranial nerves 9 through 12 that are all within that carotid sheath or carotid space. So when we think about this complex anatomy around the jugular foramen, where we have 9, 10, 11 going over the head of the bird, we're looking very closely at the cortex of the bones around this area, and it's very close we see here to the middle ear cavity and the temporal bone that we talked about previously. So in the axial plane, we actually have the jugular foramen separated by the jugular tubercle and do a pars nervosa and a pars vascularis and these different anatomic components. So we have the jugular bulb going through the pars vascularis, and we have the smaller, more anterior and medial pars nervosa separated by that jugular tubercle in between. And same thing in the coronal view, we want to see a nice white line of the cortex around the bone, where we think about 9, 10, and 11 going over the head of the bird, and 12 coming under the beak of the bird in the hypoglossal canal and the normal jugular foramen. When we give contrast, we know there's a lot of enhancement that we see around this area. We see a lot of normal vasculature at the hypoglossal canal and obviously in the jugular foramen, where we have the jugular bulb itself all going through that anatomy. So there's a lot of enhancement. So this is an area where we want to pay very close attention to our fat saturation, and a very important place to think about the pre-contrast to T1 that shows us where there's air and fat in this area. So here's an axial graphic and the correlating axial CT. And again, we have that little jugular tubercle that sticks out, separating a pars nervosa from a pars vascularis. And here in this graphic, kind of reminding us of how we think about 9 and the inferior petrosal sinus going through pars nervosa, while we have 10 and 11 and the jugular bulb and pars vascularis, so the larger area in the back. Now, sometimes there's asymmetry here, but we think about the little pars nervosa having cranial nerve 9, the glossopharyngeal. We've got the little tympanic or Jacobson's nerve, and we have the inferior petrosal sinus draining the cavernous sinus into the pars nervosa and into the larger pars vascularis. We have 10 and 11, cranial nerves 10, the vagus, cranial nerve 11, the accessory, and we have the jugular bulb as well as a small middle meningeal artery and the little auricular or Arnold's nerve. So we think about 9 being the nervosa and 10 and 11 being in the jugular foramen, and the much smaller tympanic nerve being in pars nervosa and the auricular nerve being in pars vascularis, or Jacobson's and Arnold's nerves. So here we see Jacobson's or the tympanic and Arnold's or the auricular nerve, if you like to name stuff after dead people in those larger segments. And again, we have this very important area for all those cranial nerves when they go through those foramen. We want to see a nice fat pad below those in the extracranial head and neck, but you see how close in this graphic the large 5th cranial nerve is here compared to 7 and 8 going in the IAC, 9, 10, and 11 in the jugular foramen, and 12 in the hypoglossal canal. All of those are very close to each other. So anytime we have pathology in this area, we think about where those nerves come together if we have several cranial nerves that are out altogether. And when we give contrast, this can sometimes be very confusing because of the turbulent or slow flow in blood that happens around this area. So here we see a lot of enhancement of the hypoglossal canal, and we see the transverse to the sigmoid to the jugular bulb, all having a kind of heterogeneous avid enhancement along their course in that area. So this is an area where it's very important to compare the pre-contrasted to the post. And sometimes we see the non-enhancing 12th nerve coming out below the beak of the buzzard in the hypoglossal canal. So 9, 10, and 11 are all going over the head of the bird, and 12 is coming out under the beak of the bird. And we know that that jugular foramen is actually separated by that jugular tubercle into the pars nervosa and the pars vascularis. So that's very important anatomy of the jugular foramen that we want to think about. So now we'll look at each of these nerves. 9 and 10 are both very confusing, and they both have 4 different cranial nuclei that we think about. So 9 we think about as usually having 4 big functions. So we have a little bit of taste and sensation to the posterior third of the tongue. There's a little sensory nerve to the middle ear, so general sensory to the middle ear cavity. There's also parasympathetics to the parotid gland, and there's a little bit of motor that goes to the stylopharyngeus. So this is kind of a complicated nerve in that sense. So if we think about all the cranial nerves, if we have a cross section, so here we're coming kind of from posterior in a coronal view, and we think about this view of the brainstem on this graphic from behind with these 4 nuclei that all contribute to 9. So we have 2 efferent nuclei. So there's the nucleus ambiguus, and there's the inferior salivatory nucleus that are here kind of on the right. And the nucleus ambiguus has a little nerve that goes to the stylopharyngeus with 9. And the inferior salivatory nucleus is that parasympathetic innervation of the parotid. Now, on the other side, we have the afferent nuclei. So here's the large fifth nerve. So we have a main sensory, a mesencephalic, and a spinal nucleus that all contribute to the trigeminal or the fifth nerve. But the spinal nucleus that goes down also has contributions here to 9. So we think about those fibers as general sensory to the middle ear. Now, this is the solitary tract of the solitary nucleus that we think about a majority of it going with 7, taste to the anterior 2/3 of the tongue. But there are some fibers from that same solitary tract that go with 9 to the posterior third of the tongue, and the kind of the tongue base where we think about that special sensory. So we have general sensory to the middle ear. We have special sensory to the posterior tongue. We have the nucleus ambiguus, that's brachiomotor, that goes to the stylopharyngeus, and we have the inferior salivatory nucleus. If you remember, there's a superior salivatory nucleus that goes to 7, and the inferior salivatory nucleus is the parasympathetic innervation that goes along with 9 to the parotid. So here's just an axial view showing all those 4 nuclei that contribute to the 9th nerve, and they all come out together and go in that pars nervosa, the anterior medial part of the jugular foramen. And here's a graphic kind of showing the extracranial portions. So again, we think about 4 main cranial nuclei that contribute. So we have that stylopharyngeus muscle, and then we have fibers that go to the posterior tongue with special sensory, and we have all those fibers from 9. So those are the extracranial components of the glossopharyngeal nerve. So we sometimes see this on imaging if we think about where pars nervosa is. If you have a thin CSF bright sequence, like a space or a kiss or a fiesta or just a thin T2-FSE, we can see sometimes those little subtle nerves going over towards pars nervosa just below the pons. That's going to be cranial nerve 9 going over there. So next is 10. So 10 is also confusing, and there's also 4 central cranial nuclei that contribute to the 10th or vagus. We think about a lot of parasympathetic innervation, strangely, to the thoracic and abdominal viscera that are along the 10th nerve of the vagus nerve. We also have motors to the soft palate muscles, except for the tensor valli palatini. We have the pharyngeal constrictor muscles and the vocal cords itself. So the larynx is very important for the vagus nerve. We also have visceral sensation. So there's sensation from all these structures, including the thoracic and abdominal viscera that come up, and sensory to the external auditory canal and the external portion of the tympanic membrane. And there's a little bit of taste actually from the epiglottis and the vallecula that we think about traveling along with 10. So here's a sagittal graphic, just like what we looked at for cranial nerve 9. Now we're looking at the 10 motor nuclei. So that same 5th nerve that has the long spinal nucleus, there's a little bit down here that we think about as general sensory that travels with 10 to the external TM and the EAC sensation. That same solitary tract that mostly goes with 7 to the anterior 2/3 of the tongue. There's a little bit of special sensory taste to the posterior third of the tongue with 9. And there's actually a little bit of taste that goes to the vallecula and the epiglottis along with 10. Now that same nucleus ambiguus, the brachiomotor fibers that we talked about, have a little bit of stylopharyngeus going with 9. All those constrictor muscles go along with 10 at this level. So this graphic here of 10 shows those nucleus ambiguus supplying the motor fibers to that. We also strangely have these paired dorsal nuclei posteriorly, and this is a very unusual mixed nucleus. So we're sending efferent parasympathetic fibers to the viscera, but we're also receiving afferent sensory fibers from those same viscera. So that's a little strange there. So we have that spinal nucleus we think about mostly with 5. So that's general sensory. We have special sensory along the epiglottis and vallecula. We have the paired dorsal nuclei that are very strangely sending out efferent parasympathetic fibers to the thoracic and abdominal viscera, but also receiving afferent sensory. And then we have that nucleus ambiguus, those motor fibers. Mostly we think about the vocal cords and the constrictor muscles that happen with 10. So a similar axial graphic, again, just showing all those nuclei and approximately where they are. So if we have any central pathology here, like ischemia, a cav mal, or a demyelinating lesion, we think about that may affecting the fibers that go to 10. And we see those fibers of 10 that go over to the pars vascularis portion of the jugular foramen. So here's just a graphic highlighting and reminding us again that those long fibers of 10 go all the way down under the aortic arch on the left, under the brachiocephalic on the right, and then going back up to the vocal cords, the vocalis muscle, the thyroarytenoid muscle up high. So we want to remember that anytime we have an isolated vocal cord paralysis, we need to image all the way down through the thoracic arch, especially if it's a left cord paralysis in that area. So this is a lateral graphic, and we're focused here on kind of the neck and the upper mediastinal extracranial portions of 10. We see those four main central cranial nuclei that contribute to the 10th nerve or the vagus nerve. And we remember all those parts, including the very strange paired dorsal nuclei that are both sending out and receiving fibers to the thoracic and abdominal viscera. And we remember again, in the superhyoid neck, we have this carotid sheath or space where we have parts of 9 through 12 that all go through that area. So if we have pathology here at that location, it may affect those nerves. And specifically for the vagus or 10, we have these fibers that travel down between the carotid and the jug, the vagus nerve that goes down. And those fibers come back up in the TE groove to get back up to the vocal cords themselves. So you can imagine here, if this lesion in the infrahyoid neck, if we were to have a vagal schwannoma, a nerve sheath tumor, how the vagal schwannoma starts with a V. The V is like a wedge. As a schwannoma down here enlarges, it would wedge itself between the carotid and the jug. So a vagal schwannoma wedges itself between the carotid and the jug in that space, whereas the sympathetic plexus fibers should push them both forward. So we think about those nerves coming down with 10 and back up the TE groove to get up to the vocal cords. So that vagus nerve going down here and coming back up the TE groove, different than that sympathetic plexus that we think about at different location. So again, anytime we're doing a soft tissue neck study, we're thinking about pathology. If a vocal cord is out, we want to look all the way down the carotid sheath or space, and then we want to look back up the TE groove to see if there's a lesion at that area. And we want to remember that left, we have to go down through the thoracic arch. If you don't go down, you're cutting off, just like we're cutting off the recurrent laryngeal nerve here. We need to include that area if we think there's a left vocal cord paralysis. So next is the 11th nerve, or the accessory nerve. So we think about this as a pure motor going to the sternocleidomastoid and the trapezius. So we're turning the head and shrugging the shoulders or lifting the scapula with this nerve. So this is the only nerve that both enters and exits the cranial vault. So we have these little rootlets that come off. It's a little rootlets or an accessory nerve. They come together, they form the accessory nerve that goes up through the foramen magnum and immediately makes a U-turn and goes down over the head of the buzzard through the jugular foramen. So in this graphic of both the kind of the intracranial and the extracranial portions of the accessory or cranial nerve 11 nerve, we see those fibers coming off those little rootlets that go up foramen magnum and come down the jugular foramen. So here's just an axial graphic showing the same thing. All those little rootlets that come off the medulla come together to form that accessory nerve that goes up. And then we think about those nerves going down the carotid sheath or space and passing under the sternocleidomastoid. So there's a little branch that goes to the SEM. And then the fibers continue in what we often call the posterior cervical space to get to the trapezius. So we're turning the head and shrugging the shoulders. This is a purely motor nerve at that level, cranial nerve 11. So again, 9, 10, and 11, we have all these nerves that go over the head of the bird. So if we're trying to see these little rootlets down low, if we think about our CSF bright sequence, we might see these little rootlets coming off down low that are going over towards the jugular foramen when we think about cranial nerve 11 going over towards the jugular foramen out laterally. So that's the anatomy of 9, 10, and 11. So there's some important pathology that we think about that occurs around the jugular foramen and this area. And this is a big deal to us because sometimes if we have a well-done bone algorithm CT and we have a contrasted MR, we can sometimes tell you exactly what the pathology is if we pay attention to the vector of spread the extension of the tumor and the MRI characteristics, as well as the CT osseous changes. If we pay attention to those three things and we have a lesion centered to the jugular foramen, we can sometimes tell you exactly what the pathology is. So we do have some pseudomasses here. We often have asymmetry of the jugular bulbs. And every now and then we get a patient referred for biopsy of a possible metastatic lesion, because on MR, if we have swirling or slow flow of the blood, it can look like a very confusing mass at the jugular foramen, especially if the jugular foramen is much larger on one side than the other. So that may look like a mass, but if you had started with a CT, you would have seen that that's just a pseudomass here with asymmetric jugular bulbs. We often talk about a high riding jugular bulb. I've heard people use different internal standards for this. I use the floor of the internal auditory canal. So if the jugular bulb goes above the floor of the IAC, the internal auditory canal, I'm going to call that a high riding jugular bulb. Now we may have the entire jugular bulb go above the floor of the IAC, or we may have just a diverticula go up at that location. That high riding jugular bulb is very different for us than a dehiscent jugular bulb. So here we see on otoscopic view a very purplish mass behind an intact tympanic membrane. We see a good light reflex. We see the long process of the manubrium of the malleus going down. And here in this graphic, we see that we have lost the jugular plate or sigmoid plate that should separate the jugular foramen from the hypotympanum, the bottom of the middle ear cavity. So anytime a patient shows up with a blue mass behind an intact tympanic membrane, our job is to try to figure out if the jugular bulb connects with that mass. So here's the cochlear promontory. We've got a soft tissue mass filling the hypotympanum over the cochlear promontory, and we see how we've lost that jugular plate or sigmoid plate that separates the jugular bulb from that mass, and we see avid enhancement there. So that's a good appearance for a dehiscent jugular bulb at that level. So here's an axial bone algorithm from that same case, and here we see that we have the jugular bulb at this level, and we have soft tissue that's going up into the hypotympanum, and it's going right up into the round window niche at that level. So anytime I want to see the round window, I find the basal turn of the cochlea, and I look posteriorly and laterally. There should be air right here. That's where the round window is. So here I have a dehiscent jugular bulb that's going right up into the round window at that level. So we can have a high riding jugular bulb, we may have a dehiscent jugular bulb, or we can have a diverticula. If we have a thumb sticking up where it's not the entire bulb, but a thumb is sticking up, we sometimes call that a diverticula, like a hitchhiker's thumb sticking up above the floor of the IAC. So that's a good appearance for a jugular bulb diverticula. And these may extend up very high. So here's one we see well above the internal auditory canal. We see the cochlea and the vestibule, and we think about where the endolymphatic duct and sac are coming off the back of the vestibule at this level, and we see that this jugular bulb diverticula extends way up to that level. Those diverticula can go superiorly, but they may also go medially. Here's an example of a diverticula that came medially. We see nicely correlating on this axial MRV collapsed view and the correlating CT examination. We see an enhancement similar to what we see in the vein at that level. So that was a medial diverticula. Now, if we have a patient with a clotting problem, we remember that, and we might see thrombosis of the transverse sinus at this level and the superior sagittal sinus. We pay very close to our sequences, and this is an area where the pre-contrasted T1 might be very bright, like we see here in the superior sagittal sinus thrombosis. This is a pre-contrasted T1. The nose is dark here, the nose, and I see that this is very bright in the superior sagittal sinus. So that's a good appearance for thrombosis at that level. But we know that that thrombosis may extend down along the transverse sinus and may reach the jugular bulb at that level. So here we see clot going from the transverse around the sigmoid to the jugular bulb and extending down into the suprahyoid neck and the carotid sheath or space. So that's a good appearance for jugular bulb thrombosis. Now, another pathology you want to remember, as we mentioned, the vagus nerve or cranial nerve 10 goes all the way down under the aorta on the left and the brachiocephalic on the right. So cranial nerve 10 pathology may cause a vocal cord paralysis. We talk about a Spinnaker sail sign as being the primary sign of a cord paralysis, but we might see thickening of the area epiglottic fold, and enlargement of the piriform sinus also in these cases. They're thought of as more common on the left than right if it is unilateral. And again, we want to image from the skull base all the way down through the AP window under the aortic arch. If we have a patient with a thyroid carcinoma like this patient here that extends back up into the TE groove, this patient may present with a vocal cord paralysis. So the primary sign is that spinnaker sail shape. So we see here that sail. The secondary signs are widening of the thyroidnoid groove, the space between the thyroid cartilage and the arytenoid. We have anteromedialization or thickening of the area epiglottic fold, and we have prominence of the piriform sinus, along with asymmetry of the arytenoids. Those are all the secondary signs of a cord paralysis. So we can think about this little sail shape right here. Here's the sail of a spinnaker sail. That is the shape that we see of the airway, a very dark black spinnaker sail. That's the primary sign of a cord paralysis. Now, we may also see correction of this if we have a cord paralysis. So we might see injection of materials such as radiase that may be high density, like in this case, if we're trying to move that paralyzed vocal cord back towards the midline so that the other cord can oppose it for improved vocalization in that patient. So anytime we see high density like this behind a cord that we think is paralyzed, we want to remember that that could be a radiase injection of a patient who previously had a cord paralysis. Now, with all of these muscles, we may see denervation changes. So with cranial nerve 11, we know that goes to the SCM, the sternocleidomastoid, and the trapezius. So if we see denervation of cranial nerve 11 and the trap, and this patient has not had surgery or any other history, then we think about denervation changes. And in this patient who had a neck injury and cranial nerve 11 denervation, we see how the trap and the SCM both has showed denervation changes and wasting on this case. Now, if we have a lesion centered right at the jugular foramen, this is very important because if we have a well-done contrasted MRI and the correlating axial bone algorithm CT, we can sometimes tell you exactly what the pathology is if we pay attention to how that pathology affects the normal anatomy at this site. So here's a normal graphic. Again, we have 9, 10, and 11 going over the head of the bird, and then we have 12 coming under the beak of the bird through the hypoglossal canal. So we have the jugular bulb in 9, 10, and 11 going through the jugular foramen. And when we give contrast, we know that normally there's a lot of enhancement around this area. Here's normal 12 coming out the hypoglossal canal, a lot of normal enhancement around it. And we have the internal jugular vein with the jugular bulb that gives us normal enhancement over the bird itself. So we want to see a nice black line on MR or a nice white line on CT around the cortices of the normal osseous structures at this level. So if we have an unknown case that's centered at the jugular foramen, there's a lot of different pathologies we should think about. And we want to pay attention to both the MRI findings and the CT. This is an area, just like a lot of the skull base, when we think about the anterior, the middle, and in here, the posterior skull base, we know that both CT and MR are complementary. So if I have a contrasted MR, I don't feel bad about recommending a CT. And if I have a CT, I don't feel bad about recommending an MR, because I know if I have both, I'm much more likely to tell you exactly what the pathology is. There's a lot of different things we could think about at this site. And we have a lot of differentials we think about on imaging. So here's one pathology case. Here we see destructive changes to the bones. And we've kind of debeaked the buzzard at this level. And we see what looks like a lot of flow voids in this lesion. So that's one particular pathology we might see at the jugular foramen. Here's another pathology. Here we have smooth scallop margins. Similarly, we've kind of debeaked the bird. We've cut off the beak, but now we have smooth scalloped, almost surgical margins of the bones at that level. Again, here we see on this CT the nice white line of the cortex of the outside of the bone at that level where the jugular bulb is. Here we have another case. Here we have some soft tissue in the hypotympanum going up over the cochlear promontory in the middle air cavity. We see a little bit of increased density to the bone adjacent to that area. And here we see an enhancing mass that looks like it has dural tails kind of extending in all directions on the correlating coronal post-contrasted MR that correlates nicely with this coronal CT. And here's another case. Here we have a marrow replacing process. So here on this coronal pre-contrasted T1, we see the normal bright marrow fat in the occipital condyle in the head of the buzzard, the bird, on this side. But on this side, we have a marrow replacing process. So we're going to go through a big differential and try to figure out what the patient has a history of. Mets, myeloma, lymphoma, leukemia, plasmacytoma, EG, sarcoid. There's a lot of things that could present as a marrow replacing process in the skull base. Here's another pathology. Here we have kind of enlargement and thinning of the beak and the head of the bird. So this is very different osseous change than those other pathologies. So those are the spectrum of pathologies that we see around the jugular foramen. And again, if we think about both the CT osseous changes and the MR and the enhancement and the MR characteristics, sometimes I can tell you exactly what the pathology is if we have a lesion centered at these locations around the jugular foramen. Now, here's that case we looked at with smooth scallop margins. We see nice straight lines of those osseous structures. And part of it looks like we've lost the cortex, but some of it, the cortex seems to have remodeled. So it looks like the osteoblasts and the osteoclasts have had time to keep that cortex intact, but other areas look like smooth scallop margins, almost surgical margins at this level. And I know that that is a great appearance for a schwannoma of the jugular foramen. So I have a nerve sheath tumor that is slowly enlarging and having smooth scallop changes to those osseous walls. Here's another case. Here, on this case, we see these permeative destructive changes to the bones around the jugular foramen. And again, that debeaked bird. When I see permeative destructive changes, I know that's what we see with a paraganglioma. This is a very vascular lesion, and we have these kind of rarefication. We have permeative destructive changes to the bones around that area with this very vascular mass. Now, here's a case where we have an avidly enhancing lesion with what looks like dural tails extending in all directions along dural surfaces and extending up into the hypotympanum in the middle ear cavity. And I know that if I have an extraaxial mass that's avidly enhancing with dural tails, that's a great appearance for a meningioma anywhere in the head, especially at the jugular foramen. So here we have a nice graphic that correlates with that MR, where we have a coronal post-contrasted MR with dural tails going into the internal auditory canal, over the head of the bird in the jugular foramen, and extending up into the hypotympanum and to the middle ear cavity, as we see correlating nicely here on this graphic. So here's the next case. Here we have a marrow replacing process. So whatever the patient has a history of, that could be a marrow replacing process, I'm going to think that is what's most likely here. Mets, myeloma, lymphoma, leukemia, plasmacytoma, e.g. sarcoid, any of those pathologies may present as a marrow replacing process here in this coronal T1 pre-contrasted, where I have normal fat on one side and I have replaced the fat on the other side. So anytime I have a marrow replacing process like metastatic disease, I know that that can be something that's very obvious on the pre-contrasted T1. And again, depending on if you pay attention to your fat saturation or not on your post-contrasted imaging, that may be a lot more confusing, where the pre-contrasted T1 clearly shows you where there is fat and where we've lost fat in a marrow replacing process. So here's that next pathology. Here we have thinning of the beak of the bird and elongation at that area. So again, we think about 9, 10, and 11 going over the head of the bird. This looks like something coming out under the beak of the bird in the coronal view with thinning and elongation of the beak. So that's a good appearance for a hypoglossal schwannoma. So this is a schwannoma of the 12th nerve that we see here in this coronal CT with that thinning and elongation of the beak at that level. So if I have a pathology at the jugular foramen and I have these permeative destructive changes, I know that's what we see with a paraganglioma. So that can help me make the differential in these cases. So these patients with a jugular foramen paraganglioma, they may show up with pulsatile tinnitus, especially if that lesion is extending up superior and laterally into the middle ear cavity. On otoscopic view, they may show up with a red mass behind an intact tympanic membrane. Now, interestingly, any of those cranial nerves may be out with a jugular foramen paraganglioma, any of those nerves 9 through 12. And we might see multiple lesions. We know that there's a familial MEN type where we might see multiple paragangliomas. So we want to remember to look down in the neck for a carotid body tumor or a glomus vagale centered 2 centimeters below the skull base if we think the patient may have the familial multiple paragangliomas. Now, if we just have a small paraganglioma sitting on the cochlear promontory, we often call that a glomus tympanicum. Those will present with a very red mass behind an intact TM, but that is different than where 9, 10, and 11 are going over the jugular foramen. We want to remember all the time, though, that this is our job. If the neuro-ontologist looks in the ear and sees a red mass behind an intact tympanic membrane and a patient with pulsatile tinnitus, it's my job to tell them, is this just a small glomus tympanicum with an intact jugular plate or sigmoid plate separating that tumor from the jugular foramen, or is it actually a jugular paraganglioma that is centered at the jugular foramen? And theoretically, if we wait long enough, we think about the superlateral vector of spread of that jugular foramen paraganglioma through that jugular plate or sigmoid plate. So that lesion, if we wait long enough, will extend up into the hypotympanum. And if we keep waiting, it's going to start to destroy the bones around this area. It'll erode into the buzzard head, into the head of the bird, and we'll see those permeative destructive changes. And as it continues to enlarge, we may have any of those cranial nerves out. Any of them 9 through 12 may be out with a large jugular foramen paraganglioma at that location. Now we want to differentiate a paraganglioma from a schwannoma. So with a nerve sheath tumor like a schwannoma, we think about where 9, 10, and 11 are going over to the jugular foramen. So our vector of spread with a schwannoma is up towards the brainstem. So it'll be down into the carotid sheath or space inferiorly, and superiorly, it should extend along 9, 10, and 11 towards the medulla and the brainstem up higher. So here we're going to have a mass that's filling the jugular foramen, and we have sharp expansile changes to the osseous walls. And we remember all those structures. We're not going to see the salt and pepper appearance that we talk about with a paraganglioma if we think about a schwannoma. What we do see, though, sometimes with a schwannoma is intratumoral cysts. So here on the sagittal post-contrasted MR, we have an enhancing lesion going through the jugular foramen, and we see an intratumoral cysts. Most of it is avidly and homogeneously enhancing. We see how it pushes the jugular bulb and the jugular vein anteriorly. Now, interestingly, any of those cranial nerves 9 through 11 may be out with a jugular foramen schwannoma. And just because one cranial nerve is out does not mean that that is the cranial nerve involved with the tumor. Some cranial nerves are more sensitive to external compression than others are to internal derangement. This is a good example of that theory because we may have a schwannoma of cranial nerve 9 and the patient's 10th cranial nerve may be out in that case. Also, we look very closely at the pars nervosa and the pars vascularis. I've had some cases where it looks very clearly like the lesion is within the pars nervosa, but it was not cranial nerve 9 that's affected. So when we do have a schwannoma in the jugular foramen, the normal anatomy that we think about with pars nervosa and pars vascularis is distorted. So just because we see a schwannoma in nervosa, that does not mean that cranial nerve 9 is involved. So pars nervosa starts with N. We think about cranial nerve 9 starts with N, going through pars nervosa, and cranial nerves 10 and 11 going through pars vascularis. But two very important theories here. Just because one cranial nerve is out does not mean necessarily that that's the cranial nerve involved with the tumor, and the anatomy is distorted at the jugular foramen. So even if the tumor is clearly in pars nervosa or pars vascularis, we cannot make a determinant of which nerve based on that because the normal anatomy is distorted in that area. So here's an axiographic, axial post-contrasted MR with fat saturation. We see an enhancing lesion. If we see the lesion going over towards the jugular foramen, and we want to try to differentiate that from the hypoglossal canal, if we actually have a hypoglossal schwannoma, that helps us with our differential. Now with the meningioma, the jugular foramen, we have a centrifugal, it goes in all directions, vector of spread. we see permeative sclerotic changes. So we might see increased density to the adjacent bone. It's very rare to see the flow voids, not like the salt and pepper we see with paragangliomas, and we usually see avid enhancement. So the meningioma, when they're small, may mimic the paraganglioma. So paragangliomas have permeative destructive changes to the bones when they get big enough, so we have a decreased density, but meningiomas have an increased density, a hyperostotic reaction that happens to the adjacent bones. So here's a coronal graphic of a jugular foramen meningioma. So it extends in all directions. We see dural tails, and we might see increased density to the adjacent bone. So that vector of spread for a meningioma is in all directions. The CT findings are permeative sclerotic, so we might see increased density to the bones around the jugular foramen if we have a jugular foramen paraganglioma at that location. So here's a axial bone algorithm CT, and we see increased density to the bones around the jugular foramen. And when we do a coronal post-contrasted MR here with fat saturation, we have an enhancing lesion centered at the jugular foramen. We see it extending up, similar to a paraganglioma with a superlateral vector of spread into the hypotympanum, but it's also extending into the interlaudatory canal, and it has dural tails extending along the foramen magnum in that area. So increased density to the bone is good for a meningioma. So we want to think about all these issues. What are the osseous changes? What is the vector of spread? And what are the MR imaging characteristics of all of these lesions? So if I see a permeative destructive change with decreased density to the bone at the jugular foramen, I know that that's great for a paraganglioma. If I see increased density to the bone, I know that that's great for a meningioma. And if I see smooth scallop margins, I know that's great for a schwannoma. So the vector of spread with a paraganglioma, if we wait long enough, has a superlateral vector of spread up into the hypotympanum. The vector of spread for meningioma is centrifugal. It goes in all directions with dural tails. The vector of spread with a schwannoma is along the expected course of the nerve. So it'll go down inferiorly into the suprahyoid neck carotid sheath or space, and it'll go superiorly up towards the medulla below the pons. The osseous changes for paraganglioma, decreased density. With a meningioma, increased density. With a schwannoma, smooth scallop margins. When we think about the MRI characteristics, with a paraganglioma, we have salt and pepper. The pepper is the flow voids, the dark T1 signal, and the salt is a little bit of bright T1 signal that we think about that as slow flow or phlebosis or blood that may happen within the lesion itself. So paraganglioma on MRI is salt and pepper. A meningioma has dural tails, usually avidly enhancing, may calcify, and a schwannoma, when they get big enough, have intertumoral cysts. So we want to think about the osseous change, we want to think about the vector of spread, and we want to think about the MRI characteristics. This is very important for us because we have a CT and a post-contrasted MR. We can sometimes tell you exactly what the pathology is at this location. So with a jugular foramen paraganglioma, we talk about the salt and pepper appearance. The pepper is these flow voids. Usually it's a lot of pepper, a little bit of salt. Every now and then we see a paraganglioma that is very bright before we give contrast. Maybe there was a lot of bleeding in those lesions. Here the nose is bright, so I know this is post-contrasted study, and these are all those flow voids within this lesion. So it's centered to the jugular foramen. It may extend up superiorly, and it may extend down into the suprahyoid neck carotid sheath or space at that level. Here's another case. So we have a lesion centered at the jugular foramen. We see those permeative destructive changes to the bone. So that's a great appearance for a paraganglioma at that location. And we want to look for that superlateral vector of spread up into the middle ear. But every now and then we may see a jugular foramen paraganglioma that has a relationship to the internal jugular vein. Anytime we have a jugular foramen paraganglioma, we want to try to follow very closely and mention in our report, is the jugular bulb in the internal jugular vein patent on that side? And is it patent on the other side, and which side is dominant? So if we have a large jugular foramen paraganglioma, we want to try to figure out, is the jugular bulb in the internal jugular vein patent on that side? The relationship, though, between the jugular foramen paraganglioma and the internal jugular vein may be very intimate. Here is a case where we actually have tumor crawling all the way down in the internal jugular vein inferiorly, a very rare case of an intravascular paraganglioma that started as a jugular foramen paraganglioma. If that lesion enters the internal jugular vein, it may extend down in the vein inferiorly. And we very nicely saw this tumor clot into the internal jugular vein on the axial ultrasound here. And here on the sagittal, we saw that large tumor thrombus filling the internal jugular vein inferiorly. So that's a review of the pathology around the jugular foramen, where we have 9, 10, and 11. To finish up, we have the 12th nerve. So we think about the hypoglossal as the motor fibers to all the intrinsic and extrinsic muscles, except the palatoglossus that we think about going to 10. So cranial nerve 10, or vagus, does the palatoglossus along with the constrictor muscles and the vocal cords. Cranial nerve 12, we think about as the 4 intrinsic and 4 extrinsic muscles. All of them except the palatoglossus are innervated by 12. So the vagus nerve is innervating the palatoglossus muscle. So here's the motor fibers. So 12 is just motor that come out anteriorly. So the nucleus is in the back, and we have an intraaxial segment, just like all the other cranial nerve. Then we have a small cisternal segment that goes over to the hypoglossal canal. And in the coronal plane, again, we remember where that branchial motor nucleus is and all those fibers that come out under the beak of the bird in the coronal plane. So 9, 10, and 11, jugular foramen over the top, and 12 under the beak of the bird below. And here's a graphic showing those extracranial portions of 12 as it comes out with all those fibers. So just like 9, 10, and 11, 12 partially goes through the carotid sheath or space in the suprahyoid neck, and then comes out to go to the intrinsic and extrinsic muscles of the tongue. So we have 4 intrinsic and 4 extrinsic muscles of the tongue that change the shape of the tongue for swallowing and vocalization. The intrinsic ones, we have a superior and an inferior longitudinal, then there's a vertical and a transverse, and the extrinsic muscles of the tongue are all the ones that have the word glossus in it. All of those are innervated by 12, except the palatoglossus that's coming off of 10. So again, on our very thin sequences, if you're looking at a KISS or a SPACE or a FIESTA or T2FSE, we sometimes see very thin linear structures going over towards the hypoglossal canal. That's going to be our 12th cranial nerve for us here in the axial and here in the coronal oblique reconstructions, where we can see 12 going over to the hypoglossal canal. Just another picture where we nicely see the hypoglossal canal with the normal black cortices here on the outside and the very thin cranial nerve 12 going over to it. There's a very dense venous plexus here, so we might see a lot of enhancement in the hypoglossal canal normally. Again, in the coronal view, 9, 10, and 11 going through the jugular foramen over the head of the bird, 12 is coming under the beak. And if we have elongation of the beak of the bird, like in this case, similar to that one we saw earlier, we think about a hypoglossal schwannoma. We might have intact cortices, but we have widening of the hypoglossal canal on this side compared to the normal side. And when we give contrast on our MR, we see intratumoral cysts. The surrounding soft tissues do not look very angry about this mass. The cortices are still intact with our smooth scallop margins. That's a great appearance for a hypoglossal schwannoma. Now, if we have a hypoglossal pathology, that goes to the intrinsic and extrinsic muscles of the tongue. So we may see hypoglossal denervation. So on a more delayed case, we see fatty changes of the tongue musculature on that side. Every now and then we may see a case like this. We may not know why the 12th nerve is out, but when we look at those images, it may be difficult because it might look like this side has a mass when actually this is normal tongue musculature and this is fatty replaced denervation changes on this side. And we know that there's normally some fat in that area when we think about the oral cavity and the normal sublingual space here, horseshoe shaped in the axial plane at that level. There's normally some fat at that location. So we see that mylohyoid muscle, that's kind of the floor of the mouth. So we have the submandibular space below with the anterior velizo-digastric, and we have the geniohyoid just above the mylohyoid sling coming off the mylohyoid line of the mandible. And we have the sublingual spaces on fatty filled on both sides with the genioglossus musculature and the midline lingual septum, those important spaces of the oral cavity. So early denervation changes, we might see a lot of bright T2 signal or flare signal if you're doing a brain study, and we might see enlargement of that muscle. And late with hypoglossal denervation, we'll see shrinkage of the muscle and fatty replacement. So here's an axial T1 pre-contrasted image, and we see fatty denervation changes of the muscle at that side. So if we do see a case of hypoglossal denervation and tongue musculature denervation changes, we want to look very closely at the hypoglossal canal to see if we might have a schwannoma in that case. And we want to remember those other cranial nerves that are right next to it. So if we have a hypoglossal, a tongue musculature denervation change, we want to look at the other muscles, such as the sternocleidomastoid and the trapezius, to see if they're also denervated, because we might see other cranial nerves, like in this case, where both 11 and 12 show denervation changes. Here's the hypoglossal 12 tongue musculature fatty replacement with chronic denervation. And here we see both the SCM and the trap show denervation changes. So that's a good appearance for both 11 and 12. And we think about where they come together. And if we have a case with a jugular foramen pathology, both of those may be affected, cranial nerves 11 and 12. We do want to differentiate that from an actual squamous cell carcinoma or another tumor that may happen around the oral cavity or the tongue musculature itself. So that may be confusing for us. On the denervation changes, early, the tongue may be enlarged, and we might see bright T2 and flare signal. And over time, that tongue musculature will shrink down and will have fatty replacement. It might look similar to a large tumor, as we see in this case, especially if the other side of the tongue has denervation changes. So in this case, we have a large oral cavity squamous cell carcinoma, and we see that increased density consistent with hypercellularity of this squame. So that is a review of the lower cranial nerves and their important anatomy and pathology. And again, we're thinking very importantly around the jugular foramen, where we have 9, 10, and 11. We already talked about cranial nerve 7 and 8 in our temporal bone lectures, and we talked about cranial nerve 5 in itself. That's the largest cranial nerve. So today we reviewed 9, 10, and 11, and 12, and their important anatomy around the jugular foramen. This is very exciting for us because when we think about all these cranial nerves and their very intimate relationship with the skull base, this is an area where if we pay attention to both the CT and the MRI findings, we can sometimes tell you exactly what the pathology is. That's very important for us. So just to finish up, anytime we have an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. So for most of those, cranial nerves 1 through 4, we think about their nuclei in the mesencephalon. 5 through 8, we think about their central cranial nuclei being within the pons. And the lower cranial nerves, 9 through 12, we think about their main nuclei in the medulla down below. For most of them, if we image from behind the pontomedullary junction through the face, we cover the area of interest. But we want to remember with the lower cranial nerves, we have the vagus nerve that may go down under the aortic arch. That's very important for us because if we have a vocal cord deficit or a vagal nerve problem, we need to image all the way down through the aortic arch in that area. So we want to remember that anatomy and remember the pathology imaging that happens to that anatomy. And I thank you very much for your attention.
Rick, thank you very much for this absolute exquisite lecture on the applied anatomy of the lower cranial nerves. It just again emphasizes the art and science of head and neck radiology. And basically, you need to be a neuroradiologist and then get stuck in the skull base to enjoy the magic and the perils of head and neck radiology. The inboxes are now open. Any questions?
Now you know everything I know about the cranial nerves.
Rick, while we're waiting, what are your basic sequences that you would use if a patient presents with a complex lower neuropathy or isolated neuropathy. What are the on MR the basic sequences?
On MRI, I want to do an axial and a coronal T1. So I get an axial and a coronal T1 without fat saturation. Do not do fat saturation on your pre-contrasted imaging. It's a waste of time. When we think about the skull base and the extracranial head and neck, where there is air and where there is fat is very important. So we want to do an axial and a coronal T1 through the skull base. I do either a axial T2 FSC with fat saturation and a coronal stir, or you can switch those, whichever is better on your scanner. And then I do a thin post-contrasted axial and coronal T1 with fat saturation. We want to get pretty thin images there. So maybe a 3-skip-0 or a 4-skip-1, depending on your scanner and your vendor, how you can do it. But we want to look at that area very closely. Some of the clinical presentations is very complicated here. If we think about, for example, a patient that does have pulsatile tinnitus, we want to think about the vascular entities that may have an imaging finding with pulsatile tinnitus. So if we think about a jugular paraganglioma, a glomus tympanicum, a dural AV fistula, an aberrant carotid, a persistent stapedial artery, or a dehiscent jugular bulb, if we think about one imaging study that includes all of that anatomy and pathology that may happen, usually we're either doing a contrasted CT or a contrasted MR with thin sections. Interestingly, in the patients that I have in my practice with either non-pulsatile or pulsatile tinnitus, there is this phenomenon of kind of a third window effect where we have a breach of the otic capsule or extreme thinning of the bone adjacent to the dural venous sinuses that are adjacent to the mastoid air cells. Because I want to see those mastoid air cells so well, I've actually moved away from doing an MR. And for my patients with pulsatile tinnitus, I'm now doing a CTV phase temporal bone CT study. And I've actually been doing either pulsatile or non-pulsatile tinnitus cases. So anybody with tinnitus now that comes to my shop, I've been doing a CTV, a venous phase temporal bone CT with thin axial and coronal bone algorithm sections to try to see all that anatomy as best I can. So depending on your vendor and how thin sections you can get, you want to do a pre and a post-contrasted. Don't ignore the pre-contrasted. A lot of people in a lot of places of the body just jump to the post-contrasted to see what's enhancing. But around the skull base, we really want to pay attention to those pre-contrasted T1s because where there's air and where there's fat is very important. Just like when you're looking at a soft tissue neck CT, you want to window that something like 440 so that air is different than fat. Because where there's air and where there's fat is very important in a lot of pathologies in the extracranial head and neck.
Thank you, Rick. Any questions in the inbox?
No, no more questions, Professor.
Okay, we're right on 9 o'clock. Rick, thank you very much for this exquisite lecture.
Thank you, sir.
We really appreciate that we can record this lecture. I'm very sure that many members will revisit it on our website, and we're looking forward to or rather reluctantly looking forward to the last of your lectures in a month's time on lymph node imaging. Thank you very much and have a good day.
Okay, you too. Thank you, sir.